Welcome to Family Medicine Grand Rounds. I'm Tom Peterson, I'm the department chair, and it's my privilege to let you know that today we're hosting the Laura Mann Endowed Integrative Healthcare Series. And before we get to our distinguished speaker, I'd like to introduce some special guests this morning. This is application to family medicine residency season, and we're absolutely delighted to have 5 applicants visiting us from around the country today, and I'd like to just recognize them by name, and if you have just wave your hand so everybody can see you, we hope you have a terrific day. Feel free to call on any of us, and we'll try to make it a special day and useful for you as you visit us. So first is Allegra Perillo from Brown University. Second, Mona Shao from the University of North Carolina. Welcome.
The heels.
Also from the University of North Carolina, Ray Antonelli. James Hill from the University of Alabama. And then John Najikowski from Albany Medical College. Welcome. So, as I mentioned, we're really privileged to host the Laura Mann Integrative Healthcare Lecture Series. Let me just tell you a little bit about Laura Mann. Laura Mann was a nurse midwife. When she was diagnosed with stage 4 breast cancer, she integrated Western medicine with complementary and alternative medical therapies. She created a center devoted to promoting the benefits of integrative health care to others. Now, despite her untimely death, Laura's vision is alive through the endowed Laura Mann Integrative Healthcare Lecture Series, which brings many distinguished leaders to the University of Vermont to share their best practices, research, and innovations in integrative healthcare. So this series is sponsored by UVM Integrative Health, which is a joint endeavor of the University of Vermont College of Nursing and Health Sciences, the Lerner College of Medicine, and the University of Vermont Medical Center. So it's my pleasure to introduce our fall 2017 Laura Mann Integrative Healthcare visiting professor, Tracy Jackson, who will be presenting Opioids and Chronic Pain, Cultural Myopia, and the Big Picture. Her talk is especially timely as our own organization is developing and sustaining a pain clinic which will offer integrative therapies. Dr. Jackson is an associate professor of anesthesiology, Division of Pain Medicine at Vanderbilt University Medical Center. She created and directs the Vanderbilt University's Pain Fellowship, has co-authored opioid prescribing guidelines, and is actively involved in advocacy surrounding this issue. She's certified in medical acupuncture and yoga, and she founded both Relief Retreats, which is a functional rehabilitation program for chronic pain, and also campaign.org, a nonprofit dedicated to increasing access to effective non-opioid pain management strategies. So please join me in welcoming Dr. Tracy Jackson.
Well, hey, y'all. Thanks so much for having me. I'll go ahead and talk out my similarities of interest. One, you've heard before. The second is just to say that I'm sort of a hippie like y'all, and I figured out how to dress there in the cold. So to give you a little background about myself, I was raised on Route 5, Box 265 in Washington, North Carolina, and that was my picture when I was 16 years old, just getting ready to apply to college, to UNC actually, and go on this path to become what is now a chronic pain physician. And then my siblings gave me this right thing for Christmas this year, Carolina Roots and Not All Who Wander Are Lost, because what has happened is my trajectory, like so many others, has taken a very windy path to get where I am, and I think that's why I had this perception that all of us, including this little girl, look at things through a very narrow focus, particularly when it comes to things like chronic pain. And there is a whole wide world out there that can teach us otherwise. One of those things was when I went to Beijing about just after I'd become a pain physician at Vanderbilt. And I found in China, they have 2 whole different hospital systems, both of which are covered by the government. And so you can self-select which type of the hospital you want to go to. And they have the Western hospitals, and if you go there, it looks like NASA Space Center. You know, it puts all of our hospitals to shame, and they do intrathecal pumps and spinal cord stimulators and everything you can imagine, transplants, you know, you name it. Acute care, very good. And then they have traditional Chinese medicine hospitals, whole other hospital systems. This was their pharmacist, and this is their pharmacy in this traditional Chinese medicine hospital. And patients can self-select. And when I talk to the patients, if anyone had chronic pain, they almost always self-selected for the traditional Chinese medicine hospital. Almost always. And so I started thinking, you know, this is kind of, is this an easy choice, a hard choice? You know, what are we running into here? But I think it's kind of time we look at this from a different perspective. And this was hard for me, right? Because I grew up this sort of very valedictorian, wanted to be the best at everything. I started out as a surgeon, and so the concept of acupuncture, you know, and stuff like that really kind of freaked me out. And plus, you know, my grandma would always say, you can't do yoga, you're a Christian. So I just decided, you know, you kind of have to just show up and, you know, tell the truth and let go of the outcome, and that's what I decided to do. So I went on this pathway where I wanted to learn more about it so I could research more about it, so I could talk to my patients in the South more knowledgeably about it. So I became a medical acupuncturist, I became a yoga instructor, and I also, just Tuesday, sat for my addiction medicine boards, because what I am realizing is that it's all kind of in the same pathway. It's all the same stuff, right? If you take a big picture back, if we get out of our fields, out of family medicine, anesthesia, surgery, and we look, some of the patients that are the biggest problems that frustrate us the most, right? The ones with irritable bowel syndrome, which go to GI, and then interstitial cystitis that go to the urologists, and fibromyalgia that come to me, and psych and addiction and all this kind of stuff. Addiction's addiction. It's a maladaptive process. We know it's a chronic relapsing brain disease. Impulse control disorders can kind of fall into that. And when you look at it, what I realized and what I saw in my patients through all these different lenses is that all of us tend, particularly when we're physicians and stuff, to be human doings instead of human beings, right? We're all running around trying to be fit 25 hours into a 24-hour day, right? And this fundamentally changes the way your brain and spinal cord process pain. All this sort of internalized stress that we're having is the same when you look at diabetes literature, heart disease literature, insomnia, depression, addiction, chronic pain. These are the areas of the brain that light up under functional MRI. And all these areas are associated not just with sensory and discrimination, like where is the pain? That doesn't really light up. Where's the addiction? It's all these your reward pathways, your emotional pathways. And this is what I kind of refer to just when I talk to patients. And it's not entirely accurate, but I kind of call it the lizard brain. You know, we all kind of have it. And so when I'm thinking about big picture, about how we approach this as a society, as a culture, we have to understand this. This is not taught in medical school. I did not learn this in medical school. Vanderbilt students are not learning this necessarily right now in medical school. And in fact, there was a North American medical study that said the vast majority of patients or people in North American medical schools get an average of 2 hours incomplete and sparse total education about chronic pain, even though it's the #1 presenting complaint to U.S. doctors, and we see it all the time. But we get education about morphine pharmacology, right? We don't get education about this. And what I tell patients is when you have chronic pain, or if you have had traumatic event in your past, or you have a really stressful life now, your brain perceives a saber-toothed tiger running around there, right? And there's this part of your brain called the amygdala. Its whole job is to answer the question, am I safe? And if the answer is no, what tends to happen is if the answer is yes, it goes up to your brain and you can be logical and rational and, you know, go about your day. But if the answer is no, you get a signal. That stress sends a signal to the hypothalamus, to the pituitary gland, and you secrete 2 chemicals primarily. This is really simplified. The 2 chemicals, one is adrenaline, right, which makes you wide awake, stressed, anxious, insomnia, and secretes cortisol, right, which affects your immune system and helps you prepare and regenerate sort of for the task ahead. And these things can cycle back and forth, and this is what I see all the time with patients with chronic pain. They're really, really anxious. They go, and then what you see is they get adrenal fatigue, and they crash, and they go back in the cave, right? So they cycle between really anxious and really depressed. And you tell this to a patient with chronic pain, every single person understands it. They all see these patterns. And what fundamentally is true is that you know what soothes somebody whose sympathetic nervous system is on high alert? Opioids feel awesome for that. And you know what happens when you give somebody a steroid injection? Give them a little cortisol to get them out of the caves. And how long do they say their SI joint injection helps them if they've had chronic pain 20 years? Like 2 weeks, 2 months maybe, right? So it's not that these things aren't effective or helpful in some ways, but if we just are doing them in a vacuum and not looking at the big picture of what's going on underneath, we're doing patients a disservice. We're just spending money right and left, and the outcomes are abysmal. Our outcomes for chronic pain are abysmal. $650 billion a year, and our outcomes are worse than the world because we are trying to intervene, we're trying to cut, we're trying to cure, we're trying to give a medicine for every symptom, and we're missing this underneath. So that's the critical thing to sort of understand. You'll notice that I'm not quoting you a lot of studies up here, because I tended to fall asleep when people talk to me like that. Going through, I do have data and research and references for all this kind of stuff that I'm saying, but I just think it's more effective to inspire you to think about it differently in your field, and then you can go and look more in detail. Another story that I always tell people is first time a kid doesn't want to go to school, nervous, there's a bully there. What's that kid tell mom and dad? My tummy hurts. 100% of children. Has anybody ever thought about that? They don't say their ear hurts. They don't say their foot hurts. They all say their tummy hurts. We all said our tummy hurts. And the thing is, our tummy did hurt. It's because those nerves that go to the guts, those afferent nerves to the guts, are sympathetic nerves, right? They respond to the sympathetic nervous system, to the adrenaline. So when that happens, those kids feel pain in their stomach. It's an emotional, physical response to an emotional issue, right? They're not making that up. So patients that kind of say, well, I'm so sick of people telling me this pain is in my head. This isn't a physical response to an emotional issue that 100% of us have. It's how we're evolved. And in fact, there are loads of data, particularly in the pediatric literature about adverse childhood experiences, probably in the family medicine literature as well. And these things, if kids experience these adverse childhood events, so about 30% of us are lucky and don't have any, but about almost 20% of us have 3 or 4 of these. And the more adverse childhood experiences you have while your central nervous system, sympathetic system is developing, which is up to about 22, 25 years old, it sensitizes those nerves. And so they process pain differently. And look at these things. I mean, most people, in fact, everyone in my pain clinic has several of these, right? So it doesn't mean just because you have chronic pain as an adult, you had a crap childhood, but it certainly is a risk. And particularly in our country now, and this is why I took issue with Trump's thing, that we can get rid of this opioid thing in a generation. Let's do it, right? Well, the biggest risk factor for developing addiction, chronic pain, all this as an adult is having substance use in the household. Right? So we're already a generation behind that. So we have to recognize that what's going on is this chronic brain disease, and all this emotional stress is contributing to that for all of us. And again, the data bear this out in I don't know how many articles. But you start out with adverse childhood experiences. Not everybody gets disrupted neurodevelopment. Not everybody gets social, emotional, cognitive impairment or adoption of high-risk behaviors. But the sooner you can intervene down here with kids, the more you can prevent the early death that tends to happen from people who are struggling. So other thing that I'll say about that is I always tell people, I can't change the fact what happened in the past. But what we do know is that causes your brain right now to change and process in a different way. So I can't change what your situation is now, but we can change how we can retrain your brain. The thing is, I can't retrain your brain as fast as I can give you an epidural steroid injection, right? I can empower you to know that this is possible. We know that the structure and function of your brain can change with some of these things, no matter what your current social situation is. But it takes a village, and it's not going to be fast. So what I tell people when they say pain's in the head, it's all in your head. Yeah, it's all on all of our heads. Pain is in the brain. And here's the key. They have been told for so long that they're broken, right? I have an L5-S1 disc, that is responsible for all my problems. And they don't understand. I want to blow up every MRI scanner in the world some days, because you can do 100, and we've known this since the 90s, you can do 100 MRIs of people with no pain whatsoever, and 70% have disc bulges, disc extrusions, compressing on nerves. But we focus on it because we want people to feel, we don't want them, but we make them feel broken so that they need our services, right? So that we can fix them, cut, cure. This is what we do well. This is our Western hospital. But in reality, if you tell patients, this is how the brain is meant to work, this is your lizard brain. Of course, if you had chronic pain every day, you would feel stressed out and not sleep. Like, this is what is happening. Your brain is not broken. It's resilient. It's doing exactly what it's evolved to do. So we just need to work with that to get you better. But there's no quick fix. There's no quick fix. There's no quick fix. There is no quick fix. I cannot say that enough. But, we're all Western hospital and no traditional Chinese medicine hospital. We are all, in our culture, we want it faster, better, quicker, more convenient. I was just thinking, gosh, if I lived in Vermont, it would be awesome. Do y'all have Postmates here? You'd never have to leave your house, if you didn't want to go out in the cold. And that's not the point, right? Everybody here I've talked to is like, you get out in the cold. That's the point. You have to get out in the cold. You have to do stuff. It'd be very easy to isolate yourself in your little cabin and do nothing, but that's not the point, and that's not what we're meant to do as humans. Isolation makes it worse. And chronic pain is not an opioid deficiency. I mean, this seems kind of obvious, but it's just not. The other thing I wrote an open letter to Tiger Woods that was sort of widely shared on social media a couple of months back when he got arrested, and the thing is, again, if money and power and fame could buy a quick fix cure, do you not think this guy would have bought it? Right? But think about all the sort of stress and isolation and shame that he's been through very publicly, in the past. All this kind of stuff, this is a thing that you can do all the surgeries, you can do all the whatever, but we're never going to go back to the way it was. And we're not going to make it any way forward if we keep doing the same thing over and over. The problem, as we all know, is the insurance stuff. So I'm stating the problems here. I'll try to get to solutions later. And that, if I don't, I'll be meeting with a lot of you guys afterwards in different areas, and I'm certainly happy to speak with any of you offline. But the two options we have are medications and interventions, really. That's what insurance reimburses, and that dictates our care a lot. But I also say a lot of the things that really help people don't require that much money. You just have to explain to them why they need it. So, for instance, I didn't get much training. I mean, I trained a little bit with physiatrists when I was even in my pain fellowship, certainly not in my residency. But it's like there are 32 vertebrae, and 99% of the procedures that we do for pain are addressed, surgical or interventional, are addressed at these 32 vertebrae, right? And we have 250 muscles and ligaments and joints that hook into this thing, right? And we don't do much to really address those. We say, go take 8 sessions of physical therapy, 2 sessions of physical therapy a week for 8 weeks to try to reverse, 30 years of this, right? It doesn't make any sense. Like, we're not educating people. If you can explain to them why that happens, they see. So this is a picture of the iliopsoas muscle and the quadratus lumborum muscle, and the iliopsoas is your hip flexor, right? And I think that's probably the thing that I see the most biomechanically that goes off in the pain clinic, because we all sit a certain way. I'm standing up here like this. Over time, one hip gets higher than the other. One muscle gets stronger, weaker, starts going in spasm and tugging on your spine and tugging on your hips and referring pain to all different areas. So these are, Travell and Simons a long time ago did trigger point maps where they show kind of where these trigger points are up in the low back, where the X's are, or in the iliopsoas muscle, that refer pain to this area. And depending on where you go in our system, right? If you go to an orthopedic surgeon with this kind of pain pattern, and they get an MRI and you have L4-5, facet arthropathy or a disc bulge or something, you might get an operation. If you come to the interventional pain clinic, you might get an injection. If you went to a physical therapist first, they might figure this out. But again, if you might even get a trigger point injection somewhere, your family practice office, which is appropriate for releasing that muscle, but you haven't done anything to change the fact that, for 20 years you're off balance, right? So we want a quick fix, and we don't contextualize it for patients what's really going on. It's the same thing with the upper extremity there on the right. If that came in a clinic, that would be a C5 radiculopathy all day long. It's just that we're hunched over all day and our scalenes go in spasm. And when we try to straighten up, it puts pressure on our brachial plexus. We get this non-dermatomal mess going down our arm, but there'll be a C5-6 disc bulge that we can intervene on, I promise. The other thing is I've gone along and learned a lot about this, these other healing things, is I realize we're all saying the same stuff. I cuss sometimes, sorry if something sneaks out. We all say the stuff. So the trigger points, the acupuncture meridians, and the yoga chakras, virtually complete overlap between them. Virtually complete overlap. So depending on where you go and how you seek care, I don't really care. If you're never going to believe in acupuncture, that's fine if that doesn't work for you. You can try something else as long as big picture we're talking about the same thing. And the other thing is we all have a choice, like as providers and as patients. And we do have a system where it's not popular to not do something, right? Because this goes back to the human being and human doing thing. To not do something to a patient. That makes us feel bad. If we say, really the best thing for you to do, and here is why, I'll educate you, is here's why, to go out and get some movement and some breathing into your life. And you know what happens? What do you think happens to the HCAP scores of a hospital when that happens? Patient satisfaction scores. I'm the most complained person at Vanderbilt, physician, and they had psychologists follow me around, and I'm motivational interviewing and leaning in and really, feeling bonding with my patients, and all they hear is no opioids, and off they go, turn me into patient affairs. But in reality, it doesn't do anybody any good not to empower them with the ability to, change their life if we're really concerned about clinical outcomes. So when some of these things don't make sense, patients are doing everything right. And again, I'm talking about the patients where this doesn't make sense. If you have an active runner, goes out, gets a acute lateral disc bulge, pressing on his L5 nerve root, give him a steroid injection, he's back to running in, 6 weeks. That is not who I'm talking about. Right? The people that have had pain for 25 years are on 17 medications. Nothing is helping them. That's when you just know that you're missing something. And what you're normally missing is this, what we call central sensitization. The brain and spinal cord are sensitized, and so you end up with these multiple medication intolerances. That's from their immune dysfunction, from that cortisol pathway. They have multiple medications because they have a bunch of different symptoms we're treating. And by the way, in Tennessee, the average number of prescriptions, you might want to guess? 5, 10, 15, 17. Right? And at that point, how do you, CYP2D6, we're trying to personalize our medicine and stuff. How do we know what is sitting on the CYP3A4 receptor when there's 17 things running around? We don't know what's helping and what's hurt. It's absolutely ludicrous, right? But this is what we do. Until now. Right. The pearl is that virtually all pain that doesn't make sense has central sensitization. That's become the end pathway. Something, whatever it is, whether it started as addiction, insomnia, anxiety, chronic pain, whatever, it has all ended up in a place where the body does not feel safe, and everything that we're doing is localized just to the body is not really being helpful. So again, I travel around quite a bit, and one of the things I found when I went to these low-income countries is that it seemed to me that they still had pain, but they just didn't have the same level of disability. So I did a systematic review and a meta-analysis. This was published in Anesthesia and Analgesia, 2 of these articles in the past year. And what I found, when you look at it, if you look at the global burden of disability, 8 out of the top 12 most disabling things worldwide are, look at it, back pain, major depressive disorder, neck pain, migraine, anxiety, other musculoskeletal stuff, right? Big picture, war, trauma, violence, poverty, all this kind of stuff. Pain and depression, 8 of the top 12 most disabling things. Happens in the surgical literature too. Look, anxiety, people with high levels of post-surgical pain, anxiety, psychological distress, preoperative pain. Has very little to do on the right with like ASA status and level of education. Tons of this stuff in the literature. But if you look at, some percentage of people with knee replacements and hip replacements are going to have severe persistent pain. But if you look at what's associated with that, it's major depression and pain in other places. Come in for a knee replacement and nobody asks you, do you have migraines, do you have irritable bowel symptoms, do you have other kind of stuff? We can predict who they're going to be, we just don't do it. We just say, knee pain, we can fix that, go. And also widespread pain. This is Chad Brummett at Michigan. He's done some amazing work in this field. There are surveys of 582 patients taking opioids for chronic pain. 50 of them are still saying their pain's 7 out of 10. What are we doing? And then 40% of them, half of them meet criteria for fibromyalgia, widespread pain coupled with depression, even though only 3.2% of them carry the diagnosis. Now that you see this, you've heard this, you cannot unsee it. When you go into your clinics and you go into your ORs and you see this, you're going to see these patients. I mean, it's going to pop out at you. And there are some things that we can do. This is something that we're trying to implement at Vanderbilt. And this is, again, from Michigan, but you take you can computerize this like we did. You take the different widespread body parts and then a symptom severity scale on the bottom that asks about fatigue and trouble sleeping. And you get patients who are getting ready to go into surgery or anywhere, just at a clinic to fill this out. So maybe they come in for knee pain, and you don't have time, but if you fill this out and you see they've got all these symptoms and pain in multiple somatic sites, you're dealing with something much different than just an isolated pain. And if you try to treat that, our pain literature is full of this. If you try to treat somebody like with a spinal cord stimulator, which works for a lot of patients in some ways, but if they're in the workers' comp system and they are stressed out and they're not getting any better, like their outcomes for spinal cord stimulation are terrible because we're not addressing what the underlying thing is, even though they have the perfect indication for it. So again, what people get, this is obvious, opioids, pills, injections. What they really need is a lot of this other kind of stuff over here on the right. This is what an integrative center does, all this stuff over here on the right. This is what you guys are getting up here at Vermont. So, let's go. One more word. I fully recognize what we're all dealing with in terms of the opioid crisis. And I say opioids all the time are kind of like they're either a canary in the coal mine or they're a giant red herring. It's not the opioids per se. It's that we're trying to criminalize and box up addiction and mental illness and separate it from pain and all this other kind of stuff. So if it's not the opioids, it's going to be something else. It could be the marijuana in 10 years. I mean, it could be anything. If we are really just trying to numb out and ignore kind of the big picture just because our system doesn't fix it, I'm just going to show up and load the trucks anyway, it's going to be something else down the line, right? And in fact, I was real proud of myself, y'all, like real proud on the opioid prescribing guidelines for Tennessee. Let's get these doctors in check. We did it. Our number of doctor shoppers are down. Our prescription morphine milligram equivalents are down by 2 billion. We're just making huge strides, right? Does it matter? Nope. Deaths are still going up in Tennessee, opioid deaths. This was from the New England Journal in 2016, says do all these things, screening, drug screen, patient agreements, no evidence any of this is really actually affecting mortality. And in fact, it's whack-a-mole, right? So 2 million with opioid use disorder, 12 million with non-medical use. Some of this we have to come to grips with the fact is iatrogenic. And then remember that adverse childhood experience cycle. All these parents, all these substance using, abusing parents, that's traumatic for their children and their household. And 50% of those with opioid use disorder have no access for treatment. Now, last night we were discussing at dinner, I think Vermont is probably I know it's better than Tennessee at providing this sort of access for treatment, but it's still we all could do more. And the other thing that blew me away when this article came out in 2016 is 1 in 5 patients on chronic pain who are prescribed opioids, this is prescribed opioids, taking them as doctor prescribed, not taking them off the street, like our people that we're just giving it to them, right? 1 in 5. 20% of the people I write opioids to are having a lifetime overdose. There's another article that said 90% of the people who overdose on prescription opioids are right back on them within a month by the same doctor. Because we don't track it well, right? I mean, we're all going, oh, how could that happen? How do I know if my patient's overdosed? They're not going to tell me because then I'll take their opioids away. Unless the family calls me, unless the ER notifies me. You know, we're working to get naloxone prescription entered into our controlled substance monitoring database. So maybe we can see when it's given in the ERs we can see, but when the paramedics give it, we don't know. So, I mean, this is something that it's happening out there. We think it doesn't happen to us, and I'm being a smart, good opioid prescriber. It's happening. And so we really have to go back to the concept of harm reduction. So now, in anybody who's on more than about 80 milligram morphine equivalents, which is only like 4 to 5 Lortab, y'all, 10 milligram hydrocodone, particularly in any opioid plus benzo combination, we're giving them naloxone, bringing the families in. You know, you can't get your prescription unless there's somebody here who can give you this naloxone. And that serves two purposes. I mean, number one, it scares them a little. Like, whoa, I had no idea this was this serious. I take it like prescribed. I said, yeah, but as you get older, your kidney function changes. What if you get the flu? What if you add an antibiotic or another medicine into your 17? All of a sudden, your relative levels go up, and you just don't wake up one day. You know, and they think about it. And then, obviously, medication-assisted therapy. This is, for those of you that haven't gone deep into the addiction literature like I have recently, I'm just studying for these boards. I mean, it's incontrovertible data that Suboxone saves lives. So much better than abstinence. It's not even close. The question is, then we've just done opioid replacement therapy. What happens? How long do you stay on the Suboxone? Right? And there have been Suboxone deaths in combination with benzos in Tennessee and elsewhere as well. But certainly in the short term, you know, if you take somebody from a purely Western system, they're addicted, they have had no integrative options, and you put them on Suboxone while insisting that they participate in these more integrative behavioral options, which does happen in other states, then you buy them time till they can work on getting their feet up from under them, incorporate these other things that are going to help them in the long term, and then you can talk about coming off the Suboxone. And most people are ready to do that, in my experience, the ones that we've tried. This was a really interesting article in that whole episode of the New England Journal in 2016, comparing this to the AIDS epidemic. So we know, just like we knew with AIDS, how it was spread, what to do, but we just can't put it together without engaging on all fronts: healthcare, the legislature, the insurance companies, all this kind of stuff. And right now, even though we know medication-assisted works, there are 30 million in the U.S. who have no access to an MD with a data waiver to prescribe it. And that's only 3% of rural PCPs and 16% of urban psychiatrists nationwide. I think Vermont may be a little better than that. Tennessee's worse. And because people are scared, right? You hear, I don't want these addicts coming into my practice. They'll scare all my other paying patients away. Or, I don't really understand addiction, you know? Like, oh, they're on heroin, and, you know, what do I do? Right? These are people just like all of us in here. And in my experience, when you prescribe patients, and in the, you know, the literature will bear this out, that when you prescribe something like Suboxone, it stabilizes people out, right? They're not constantly up, down, going out seeking, engaging in risky behaviors. They're much more stable. You know, I say it's terrifying to me. In Tennessee, I've had 3 patients come in who are on huge dose opioids and benzos, clearly have opioid use disorders, and I try to get them to go on Suboxone, you know, but I may have to, if they don't want withdrawal, they've got to go on the, you know, maybe we can do this in the hospital, out of the hospital, but I need to say that they have an opioid use disorder in the chart in Tennessee. That's just Tennessee. We like to criminalize these things and document it. But in Tennessee, they say, no, you can't do that because I need my concealed carry permit and my federal firearms license. And that's the first question they ask. It happened to me 3 times last week. You know, so there's this discussion about, is it safer for somebody who's going to have a gun anyway, or and has a guns anyway, to be on Suboxone and mandated holistic therapy, or just to be out there, doctor shopping up and down, going in withdrawal, anger, anxiety, irritability. To me, it's obvious, right? But we need to think this. I mean, this is happening out there. The other thing that's happening is NPR did this expose. That said, I can't remember. It was in 2013. It was in Hale County, Alabama. One of you guys is from Alabama, and it said that people can make more money going on disability insurance and selling their pain pills than any other advertised job with someone with a high school education. Right? So like people that are economically disfranchised, marginalized, can't make money, actually do have pain because it's stressful to be underemployed and not be able to take care of your family, and your back hurts from the manual labor you've been doing. And you can make more money going on disability and selling your pain pills. I mean, what are you going to do? Right? Does anybody know who this guy is? Some of you must. So, he's kind of a controversial figure. This guy's Paul Farmer. He's the guy who runs Partners in Health up at in the Harvard system. And I always thought it was really fascinating. He goes down to Haiti with the 4-drug tuberculosis therapy and says, yeah, we can treat tuberculosis, but I'm not going to do it unless you deal with the sanitary conditions, the water. This becomes a social justice issue again, and we want to kind of stick our head in the sand about this. But we can't. The people that are becoming addicted, it spans all of us. I mean, it goes top to bottom, side to side in terms of socioeconomic class, gender, all that kind of stuff. But a lot of the people who need it, because of the fact they have chronic pain and they're disabled, and because of the fact they had addiction, they can't get insurance and jobs, insurance or underinsured, like Medicaid, like some patients. So we have to, just cutting off Medicaid is not really going to be the answer, and it doesn't save money in the long term. I said, too, I do inpatient pain coverage for the chronic pain service at Vanderbilt, and I see at least 3 patients a day who, we have universal health care, y'all. I mean, you need health care, you go to the ED, right? So these patients are coming in with chronic pain, addiction. They get admitted for their abdominal pain, to get worked up for all this kind of stuff. 3 days later, they're on their IV PCA. You can't titrate down their opioids because they'll take as much as you can give them, right? Eventually, you just put the foot down, get the social worker involved, go back out on the street. There's no PCP, there's no health coverage, and 6 weeks later, they're back in for another $250,000 primary care visit. So this is happening, right? Whether we want to admit it or not. And so the bottom line is our culture is terrible at managing chronic stress, and our system is terrible at managing chronic illness. And so that's why things like this integrative complex pain program you guys are doing are so important and so critical. And even though we're fighting right now for how do you get funding, and yes, but if only Medicaid would do this or somebody else would do that, the more voices we have that say we have to do this. We refuse to work in a system like this anymore. It's ruining our quality of care. It's ruining my practice as a physician. The better off we're going to be with all these voices. Because if we keep spending $650 billion a year pain and all this money on addiction, our healthcare system's collapsing either way. Right? There's going to be more and more work, more and more paperwork. So this is like a really important issue of our time, and it's just chronic care. In family medicine, all these sorts of integrative strategies, holistic, long-term, low-cost, frequent touch strategies for diabetes, for heart disease, works just the same as it does in the pain literature as well. We just need a different chronic care model, one that is more integrative. So we start with pain and addiction, but it's kind of all of it. And the assessment plan, like I said, everybody I see in my clinic, you've got central sensitization. I don't tell them these words, but what it is central sensitization, chronic biomechanical dysfunction, and opioids aren't indicated. That's it. So we have a choice what we can take and which path we can go down, and this is the path I really am passionate about trying to see that we go down as much as we can. Functional rehabilitation is essentially the same thing as integrative holistic management. If you take the very sickest of patients that are on high doses of morphine, that are just disability, whole sorts of thing, and you put them in a 3-week intensive program to help them come down off their opioids and then longitudinally follow them. If you do this, 66% of people return to work, opioid use is eliminated, Healthcare costs are reduced 66%. You know, there's a way to do this. It's been done in workers' compensation for years. It saves money for the insurance company in the long run. It can make money for the functional rehabilitation programs. Patient outcomes are better. Opioid use is eliminated. It just takes some vision to do it up front, right? And we just haven't had that vision. Insurance still doesn't reimburse it. But this is 20 years of data, Cochrane reviews, everything you can think of shows that this is really the only thing that works for truly complex pain. And it doesn't necessarily have to be inpatient or 3 weeks outpatient. You probably can stratify it, we don't know, and have an intensive online outpatient sort of home-based thing. We really don't know about that. But certainly this integrative strategy is unequivocally the way to go in our literature and just in common sense. And if you want to know more about that, I did a little TEDx talk about it last year where I go into that in more detail. And fundamentally, what we have now is a spoke model, right, as opposed to the hub model. So if, let's say a survey of all of us in here, and we've got selection bias, obviously, but you know, if somebody got back pain and it didn't get better for 2 months, you know, who calls their primary care doctor? Who goes to the acupuncturist? Who gets a massage first? Who calls the surgeon? Who just curbsides their friend? Who does some yoga? Right? Like, every one of us is going to enter that wheel at a different spot. And you're going to follow that wheel all the way down 2 months. That didn't help. You're going to go back out and try a different one. And none of those disciplines, they're all going to give you a different story, right? The orthopedist is going to say it's your disc. The pain doctor is going to say, you know, you need an epidural. The physical therapist is going to say you need this. The acupuncturist tells you one thing. So people just get confused and nobody gets better. So the idea is if you have somewhere like a complex pain center where you have any pain from any source, somebody that understands it can be there and then triage. You do need to go to surgery. You do need to go to physical therapy. What are your feelings about how you'd like to try to get better? Would you like to try the acupuncture yoga route first? Let me tell you why that might work and why this maybe having a trigger point injection might help you, right? You can show them videos while they're there. That is like the first 15 minutes of my talk, right, today. So by the time they see you, they're like, oh, yeah. You know, I don't ask people the pain scale anymore, but I ask them their stress scale. On a scale of 0 to 10, how stressed are you? You get 3 kinds of answers. Nah, no, 0. So, you know, people have been persecuted, trying to hide something from it. 12. You know, that's catastrophizing. That type of anxiety is highly associated with the development and maintenance of chronic pain states. And then there's somebody that's like 7, and here's why. You know? So these sorts of questions, you can get a lot of information in a short period of time. And, you know, interface with our healthcare system is really stressful to people, right? They got 5 minutes, right? Walk in, and all you're going to say is, did that last medication work? If not, Cymbalta didn't work. Here, let's try Savella. Bye. See you in 6 weeks. Right? So, and this is creating true PTSD symptoms, both for the patients, but also for us. I mean, it sucks to see our patients not getting better and not being able to relate to this. And we're not taking care of ourselves because we're too busy doing the paperwork. So if we're not taking care of ourselves, we're not doing good self-care, how are we going to recommend that or do it to others? So, you know, there's a big push. You know, Duke is doing some good work about this, you know, physician health and physician self-care, residency programs to make sure you know, are you physician heal thyself stuff. Because if not, that's just another saber-toothed tiger to our brain. So these are some of the data to the left. These are some of the big studies, RCTs of functional rehabilitation programs. This is for kids and for adults. All to the left of the line favors this interdisciplinary, holistic, integrative plan, like for patients with chronic pain from any sort. And really, to be effective, I'd say think about having a hub and spoke model as opposed to the spoke and hub. You know, make sure you start from the hub. Include adolescents and kids. Don't be afraid of the kids. You know, include children. make sure medication-assisted therapy is associated with that, and explore these sort of telemedicine long-term coaching options. I mean, you can't just boot camp people and send them back out. That doesn't work for anything, really. So in the last little bit, I got frustrated, as you can tell, kind of a passionate person. I got idealistic, and I went to Vanderbilt, and I was like, look, I'm going part-time. Like, I'll take a pay cut. I don't care. I'm going to take a pay cut. I'm going to spend my own money. I've been trying to do this functional rehab program, and I've been running into roadblocks. We can't fund it. We don't have the space, blah, 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 blah. And I understand this happens everywhere, right? It takes a long time. So I finally just said, well, I'm part-time. I'm going to go out on my own, take my pay cut, spend my money, and I'm going to do my own pain rehab retreat. Can I do it, like, conflict of interest? And they said yes. So I took these 12 people out to the woods, and, it looks like they're from Vermont. It's a very white group, right? But this is kind of the pain population, right? 98% of the people dying are middle-aged white males with the high school education. I mean, so this is very typical of the demographic that I see in my pain clinic. But the ages were from 72 to 28. We had 2 men. We had, the rest were women, a psychologist, a physical therapist, and myself, and we were all yoga instructors, and I do the acupuncture, and we took them out there in the woods. No Wi-Fi, no cell phone. They had to eat things that didn't have GMOs, no alcohol. It was all vegetarian. We gave them a little fish and chicken that were grown right on the site. And I took them out there for 2 weeks. And 8 of them were on, and they look happy now. Okay? When they came, they were like this. Average greater than 250 morphine milligram equivalents, average duration of pain greater than 25 years, half of them on disability, 2 of them couldn't drive, and families just falling apart. So this is, I didn't cherry pick people to show my results, okay? I mean, because that's what annoys me the most with pain literature. You study a procedure, but you exclude everybody with depression who's on opioids, and I'm like, I don't see anybody like that, right? So I took the people that I see out there. And we took them in the woods, and I'll just tell you a little bit, because this was my first time doing this, and the psychologist had some experience with integrative stuff. She's in the middle laughing with the curly hair and the pink shirt. She's at University of Southern California now and was at the Osher Center for Integrative Medicine at Vanderbilt. And what she did is we sat them around in a group. The first day, we never once asked them about their pain, what they tried for their pain, tell me anything about it. We sat around the group at the beginning of the day with this little talking rock, and she passed it around, and she said, when you have this rock, you get to talk for 3 minutes, and nobody can interrupt you, nobody can change it, nobody can make it better. I'm just going to ask you a question, and you answer it, okay? And we're going to do this every morning. And the first question she asked is, what do you grieve the most in your life? And I went, oh, God. Like, here we go. Like, they're going to leave, like, bye. They just got here, and they're just going to turn around and go. And I might get kind of emotional. I mean, you wouldn't believe what comes out of that. And their pain complaints all different, their backgrounds all different. But I was thinking, we're going to say, I grieve my doctor doesn't get me, or I grieve that I was raped, and just like throw it right out there and not know how to deal. It was always, I grieve my life I had before. I grieve that I can't be the mom that I wanted to be. I grieve that my husband has to see me like this. I grieve that I'm not a productive member of society anymore, and it was pretty much universal. And I get chills thinking about it, because every one of them would have thought they were the only one in the world who felt that way. And every time they did feel that way, immediately somebody just tried to make it better for them. So even after they passed the stick off, nobody got to say anything. If you really felt that you agreed with it, you could say, "Aho," or some noise. But you couldn't say anything. And it was really kind of radical. And then the afternoon, like while this was going on, we'd watch what would happen in their bodies, right? What's the only muscle below the neck that is innervated directly by a cranial nerve straight off the brain? Right? Shoulders for earrings, You can see your accessory nerve go straight to your trapezius, so you can tell patients. Like you see what's happening when she's starting to talk about that? This is happening. So just notice in your body when you're stressed what happens, and then bring it down. And then I would give them a quick little 15-minute talk every day about why this happens, what's the science, what's going on in their body. And then in the afternoon, we do some sort of movement therapy, right? So there's me with my little skeleton. little qigong there at the bottom. That's us sitting around in the room. And then in the afternoon we do yoga. So bottom right, that's yoga. Yoga is not like twisty Instagram pose, right? Yoga is like breathing and stretching, right? None of my patients can do yoga that's offered in a studio unless it's restorative yoga or yin yoga, and even that they can't. But they can Google a YouTube video online. It's not ideal. They're not in the community, but it's better than nothing, and it's also educating them. So we did some sort of movement in the afternoon. Sometimes the movement was walking, back and forth to the yoga studio. So bottom right is walking back and forth to the yoga studio. 2 of them could do it on the first day. By the last day, they were all walking back and forth multiple times. And these are people with EMG documented foot drops, 3 and 4 back surgeries, who couldn't even walk to the car when they got there. So by day 6, they were walking around, and then on the left side, what I did is I brought in the family members. What do you think happened? Oh, falling down on the golf path, freaking out, not sleeping, pain 9 out of 10, whole thing. But then we explained to the families what was going on and what this situation was, and we involved them in the process, and we gave them the education. So involve the community. That's a lot of what integrative medicine is as well, involving the family, involving the community, involving schools and this sort of stuff. That's critical for recovery for addiction. It will be for chronic pain and all chronic illness. And then, I'm a dork and I studied this sort of stuff. So on the left is the SOAP score. That's a screening tool for opioid addiction. 17 is a marker of mild opioid risk or addiction, and mine averaged 45. You can see the fibromyalgia, and this is baseline, immediate, 4 weeks out, and 6 months out. And so you can see, keep in mind, this is 12 people, right? So I'm not going to, change the world on my N of 12. But what's dramatic to me, as you'll see, is the ones in red are the ones that are statistically significant, even with just 12 patients, and even at 6 months. So you'll see that it's not just like you got better for 6 weeks and then got worse. Like these gains were made, dramatic, and they changed, and they stayed over 6 months. So, and I looked at a bunch of stuff, and the more you look at it, the more you're going to find things that, actually benefit. But I looked at things like pain self-efficacy. One of the big arguments that's made is, well, patients who don't think that they can do anything, they think they can't do it, well, they won't do well in a program like this. They've got to want to participate, And on some level, they do want to participate, but they can still feel that they have no control over it when they go in, and you can change their mind. You can show them that they do have control over their pain experience, and that's what pain self-efficacy is. That improved more than anything. Then there was their pain behavior got better. These are all NIH-type promise metrics. Anger and anxiety trended sort of in the right direction, but not towards statistical significance. And again, we see with chronic pain, right? That's their predominant feature, anger, anxiety. Depression got better. Fatigue got better. Physical disability, pain interference, catastrophizing, sleep disturbance, all these statistically significant. Sexual function, satisfaction with social life. And then in the end, I thought I was teaching them how to these are 2 different mindfulness scales, and neither one of them seemed to show much change, even though the patients were taught and endorsed that they were participating in mindfulness by the end. The other thing I looked at, 7 out of 12 were on opioids pre-relief retreats. 4 are completely off and still off, and doing much better in their outcomes. The 2 without their driver's licenses got their driver's licenses. I get pictures all the time from people that hadn't left the house, and they're hiking up sand dunes with their family in Michigan. One's going back to massage therapy school. She's been disabled for 10 years. So this is really once I've seen this, I cannot unsee this. Because nothing else I've done in my 10 previous years in the interventional pain clinic comes anywhere close to the outcomes that I see from these patients. And I had to change some of them to Suboxone. Because they've been on big 75 mic fentanyl patches and 120 milligrams of oxycodone together. You can't just take that off without there being significant physical ramifications to that. So I put 2 of them on Suboxone, and they're still on it now. And then cost. One of my poor patients had a venous gas embolism after a laparoscopy a week after the retreat. And you hear about this, right? It's case reportable. You know, the CO2 goes in a venous plexus in her pelvis, and she got temporarily paralyzed from the waist down. 6 months and 6 weeks in the rehabilitation facility, she still reported that her pain was better and her mood was better even with that. And for having an advocate on her, you know, because they told her it was conversion disorder because she was crazy, right? And now it's taken her a long time. She's recovered. It's since been shown that that's probably what it was. But anyway, these people, when you take her out in terms of cost, 8 out of 12 of them are having reductions in encounters and payments per encounter, even in the short term. And again, we know the cost data normally will take about a year or 2 years to turn around, but even in the short term. And it's trending towards less specialty utilization and more primary care, which is ultimately what you want. So these are the sort of the key elements: wash, rinse, repeat, trigger, body awareness, soothe, central nervous system, get people out of the healthcare wheel, educate, empower people, and have frequent touches in your holistic management. Don't get stuck on semantics. You know, if some pain patient can do CrossFit and they'd rather do that than yoga, have at it, right? Breathe, move, connect with community. Compassion, not criminalization. Things we all can do: ask about pain at every location when you query pain at any location. Address it. Even if you can't fix their crappy social situation, express what's kind of going on, give informed consent, be compassionate, educate, do not promise a quick fix, do not sanction disability. Patients have to participate in their own care, and try to be and find an advocate for your patients, and also be one for yourself. If you're working too hard, you're not, you know, you got an oxygen mask. You got to put your own on before you can help anybody else out there. And then these are some of the more specific things that I know are ongoing in Vermont as well: naloxone, telemedicine, coaching for all chronic illness, educational videos, databases of online resources. All you young, savvy people, you know, should be able to put a lot of this kind of stuff together. And community and company outreach. You know, UVM, I think, is the biggest employer I heard in Vermont. There are a lot of things you can do with incentivizing people to do the right thing with regard to their wellness. If Vermont is self-insured like Vanderbilt is, you can actually reduce healthcare costs among your employees by incentivizing them to do the right things. And there are a lot of big companies out there that are doing that sort of thing and saving 25 to 35% on their overall healthcare costs while improving their employee wellness. So, I mean, it can start with us, you know, as well. And then, of course, and contingency management is bribing people, essentially, giving them rewards for doing good stuff. Legislative involvement, and you're in a small state, so there's a real possibility that you can more directly affect your legislatures and reform your insurance. And also, you guys all have, most of you have kids. You know, this can start in schools, right? You're probably already doing stuff, again, more than Tennessee. You know, I live in the blue dot in the big red state, you know. But with kids, like, this starts early. You can screen for this, do brief interventions with childhood. You know, you can educate kids. You know, I'm sure this was probably done up here in the Northeast way before in the South, but, you know, instead of punishing kids, you put them in meditation, right? You know, when they do bad things. You know, there are different sorts of ways that you can really affect things before, prophylax it before it gets to where it is now. And then I'm going to end with this little thing.
Ladies and gentlemen, it's a beautiful slide.
Can y'all see this? Hear that?
When followed in life, I guarantee you, life will be different.
Well, you can just listen, I guess.
I guarantee you, if this is applied in life, we can have peace.
Oh. Well, it basically says, do you have a problem in life? Yes? But do you have a problem in life? No? Then why worry? Do you have a problem in life? Yes? Can you do something about it? Yes? Then why worry? Do you have a problem in life? Yes? Can you do something about it? No? Then why worry? And we just get all worried about everything, you know. It will happen. The tide is turning. There's a lot of good and positive we can do. And I really thank you for coming and letting me share my opinion with you guys today. I didn't leave too much time for questions, but yes? Yes, thanks. Thanks for doing that. And, the legislators are key. And in Virginia in particular, I know they've done some amazing work with Medicaid. So what they did was take away all pre-authorizations for alternative therapies, put in heavy pre-authorizations for opioids, increase the reimbursement for what you pay physicians to see Medicaid patients. So incentivize physicians to see the Medicaid patients, trained physicians to prescribe naloxone, and then matched them. So they did an epidemiological map of Virginia and showed where the most addiction was and where all the providers were. And then they matched the appropriate medication training and treatment. They increased their number of providers, increased incentive for them to see the patients, took away reimbursements, and they have improved by 50%. The people matched with care, number of patients on medication-assisted therapy are up, number of providers are up, and they've saved 35% already in 2 years, even with all those expenditures. So there is some precedent for this happening, and I believe I am going to be talking with some of the insurers later today after this. So thank you for your comments. Yes?
Yeah, I'm a pain doc like you, and congratulations, what a great talk. My background is kind of funky, which is I was a member of Vermont's functional restoration program back when we wrote those papers. And then I built Michigan's spine trunk, so I'm actually on faculty at Michigan, and I'm back in Vermont just the last couple of months. And you know what frustrates me is, yeah, they call me a pain doc, but our research at Michigan shows that the predictors of disability, wow, I got a microphone. The predictors of disability and suffering are deconditioning and psychological and social factors, not pain. That people who have chronic pain, the level of pain doesn't relate to their disability or their suffering. And so really, I hate the name for our specialty. I'm a rehab guy, and I call myself a function doctor. Our patients are coming to the primary care doctors thinking that the coin of the realm is pain, not I can't work and my life sucks. And I wonder if you'd comment on that.
Yeah, and I think that's why it's functional rehabilitation and functional restoration rather than pain program has been sort of pushed, by Mike Hooten and all those guys kind of up in this area in Michigan. And I think one of the things that's important, if you look from even my data, the fibromyalgia survey score didn't change for these patients. Their functional outcomes changed, but they still had pain. They still would say their pain is 7 out of 10, but they were like crying to me, I got my quality of life back. You don't understand that my family asks me to go on excursions now. I can go to the grocery store. I have pain, but I know the big things that people with chronic pain develop is something called the fear avoidance model of pain, right? So they are fearful that they're going to hurt, so they avoid doing things like moving that makes it hurt. So then they don't move, then they get more deconditioned, then when they do try to move, they hurt worse. And then they catastrophize about it. Well, I'll never move again. And they get this kinesiophobia. So all these programming is about showing them how to get past that and ignoring pain altogether. So you're exactly right. Thank you. All right, I know y'all have to go, but I'm around. Thanks so much.